about what I tell you will be on these things. So let's see. Define hematology. What is it? Study blood. So what does TBC stand for? A complete blood count. And what is it? What I just wanted you to say something like there are quite a few tests that are going to give things like red cell count, white cell counts, differentials. So it's a pathology test that can really assess how that patient is doing as far as their blood chemistry is going. Okay, so exactly what is a hematocrit? Who would like to tell me what you put? Go ahead, Maya. Say it loud so the reporter can get it.
Percentage of whole blood.
The percentage of whole blood that is studied. Right, that's exactly right. And this is on here, but what's the predominant cell that we find in blood? Erythrocytes. Right, good. The next question, though, asks, what's the predominant protein found inside of red blood cells? What's that protein called? Hemoglobin. The accurate term for red blood cell is erythrocyte, and the accurate term for white blood cell is leukocyte. Leukocyte, right? Platelets are called thrombocytes. And then I forgot about the endocrine thing. So we started the other day finishing up the endocrine system, so I thought these were forgotten. I told y'all that. But they were just stacked with bonuses. So if you get some of these and miss some of the others, you may still get a 100, right? So describe what Cushing's disease is. What is Cushing's?
Either hypersecretion of ACTH or hypersecretion caused by either or extra or your treatment.
Okay. All right. So look, guys, what is Addison's disease? It's a hypersecretion of the adrenal glands. It can, what did I say? Cushing's. Cushing's. I was reading the next one. Cushing's. It's a hypersecretion of the adrenal glands. Cushing's is. So that's what it is. Now, if I'd ask what causes it, the cause can actually be because of a tumor on the pituitary causing hypersecretion of ACTH, or it could actually be because of a same tumor on the adrenal cortex. Yes.
I put
well, that's not what that disease is it? Because I got that going right now, but I don't think it has anything to do. I think it has to do with the ice cream at night, nothing to do with Cushing. Do you know what I'm saying? So you can't say that that's something. When I was asking what is it, it means that you have a hypersecretion. You're over-secreting from the adrenal cortex, that gland. Yes.
Oh, because I've written everything that you said, and I had just, so it's not a hypersecretion of ACTH?
It can be because of a hypersecretion of ACTH.
Because that's what I had put down as.
But listen, you can't define Cushing's as that, because let me tell you what else. What is Addison's?
Hypersecretion.
A hyposecretion of the adrenal glands. And what will you see in Addison's? A high ACTH. Okay, so you can't define Cushing's as just having a high ACTH. So do you get what I'm saying?
Well, yeah, but I guess I just didn't find here. You say what the actual syndrome itself was.
Okay,
when we were going over
it. So good. So that's fine, guys. This is why we do this kind of thing.
So could you repeat that, please?
Yes. So Cushing's syndrome, or Cushing's disease, is a hypersecretion of the adrenal glands caused by either a hypersecretion of ACTH or a tumor of the adrenal cortex.
Okay.
Fair?
Yes, I had the why, but not the
you had the why and what could cause it and what you might see. And Ashley had the signs and symptoms, right, Ashley? Ashley, this is actually, thank you, and this is actually like what people do. So common. And I see it all the time. Like I'll say, what is acromegaly? And what do y'all know acromegaly is?
When
what is it? I can't hear her better. Hyper what? He was
the human growth hormone.
Yes. So it's a hypersecretion of human growth hormone where the onset is in adulthood. But I think I asked that question on one of the other quizzes, and so many, not just one or two, so many say, oh, it's when you have like large, bones and the face irregularity, whatever. But you can't. That's not what it is, because other things can cause those kind of things too. Those are signs and symptoms of it. True enough, and I know what you're talking about, but that's not answering the question. The question is a hypersecretion of human growth hormone where the onset is in adulthood. So when you get asked what the cause is, describe what Addison's disease is, that's a hyposecretion from the adrenal glands. That's a hyposecretion. And what you'll see sometimes is a hypersecretion of ACTH, because that's trying to get the adrenal glands to function. But are they functioning? No, they're still not functioning because it's the problems in the adrenal glands. Did I tell you all what a pheochromocytoma is? All right, I want you all to go back to your endocrine notes. If you're in hematology right now, go back to your endocrine notes. And you write down a pheochromocytoma. Pheochromocytoma. P-H-E-O-C-H-R-O. God, okay, wait, I gotta write it. I think it's this. Pheochromocytoma. How do you like that for a word? All right, look. This, if it is an OMA, what do you know it is? Well, it may not be cancer. But it's a tumor, right? It's a tumor. Not all tumors are cancers, right? So it's a tumor of the adrenal medulla. So it's in the middle part of the adrenal glands, and it's a tumor. So what did I tell you? Tumors will often cause a hyper or hyposecretion. Hypersecretion. This is causing a hypersecretion of epinephrine and norepinephrine, if you will. So what kind of signs and symptoms might you see on this person? High blood pressure. What else? So increased respiration, heart contraction strength is increasing, heart rate is increasing. All of this stuff's increasing. These people are in a fight or flight response, and no bolus shakes in them, right? They come into your ER. And by the way, these signs and symptoms usually happen quickly, like the onset's kind of quick. And they come into your ER, and guess what you're thinking? You see this young person who has no reason to be acting like this. Guess what you're thinking? You're thinking drugs. You're thinking drug abuse. And then you have to back up and apologize to them in your mind. Because, of course, you wouldn't say that to them. But after, what'd you say? I said sometimes. Well, they probably would say, well, we got to do some screening. We got to do some, what they should be saying is we're going to do some testing. And some of the testing is going to be to rule out drugs. And they're going to ask them, what are you taking? What are you taking? What do you have in your system? And that's a legitimate question. So, and then when they say nothing, they're not, they're going to have to prove that by doing some blood work and stuff. But then the scan is going to show that there's a tumor in the adrenal medulla in the middle, causing this hypersecretion of these hormones. And y'all been in that situation where it took a microsecond and you were jacked up, right? If you can't stay in that situation long, because if you were to stay in that situation long, what is there a risk of? Heart attack, stroke. There's risk of this. So these people, once they see that there's a tumor, they go right to the OR for removal of it. And they're actually in intensive care until they can get that taken care of and that out of their system. That's intensive care. So this is a tumor that can cause a hypersecretion of the epinephrine, and y'all should know that. Okay. So this is all good stuff, because this is telling us how we should approach these questions and how we think about these disorders, right? If I had asked for signs and symptoms of that, it would have told me all these signs and symptoms. But you should also know if I ask, what is this, where that tumor actually is found. Okay. All right. I hadn't picked it up. Sorry. Okay. So excessive bleeding may implicate disease of what, or of what organ? Would you say? Liver. Why? It didn't say organ. Of the. I said of the. And why do you say liver? Because the liver secretes what? Erythropoietin. And erythropoietin is not erythropoietin. Thrombopoietin. Excuse me. Y'all correct me. See, look at y'all looking at me like, what she said? Thrombopoietin. And thrombopoietin targets the red bone marrow to make platelets. And platelets are involved in controlling bleeding. Right? So if you've got somebody with excess bleeding, you're worried about, okay, could this be a liver thing? You know, and that's not an unreasonable thing to be thinking of. You could also be thinking that maybe they were taking things that could actually block coagulation. Okay, but I was asking what organ. Enteric hormones are released from or affecting the what? The GI tract. So stomach, intestines, the entire tract. So the GI tract. And I'm not going to count those against you if you missed any of those hormone questions. But do you know that? All right, and then the bonus question says, what is the cause of type 1 diabetes mellitus, insulin-dependent diabetes mellitus, other than, I didn't want you to say it's inherited, right? There is a familial component to this, we know, but it doesn't have to be. There's some people who get diagnosed with this that have never had any history of family disease. What do we know is the cause of type 1? It's autoimmune.
Simply the isolate cells.
It's autoimmune, which means that your immune system attacks those beta islet cells of the pancreas and eventually will destroy them and you'll stop producing insulin. So that's what I wanted you to put. How'd y'all feel about this minus the hormones? Minus the hormones?
Not too bad.
Okay. All right. Like I said, we can't all be on our game today. But the days that we have tests, are you on your game?
Yes.
Not so much. I just sent, and y'all, I'm not just like reading this into y'all. I just sent this out to my micro. Kirsten, are you the only one in here that's in my micro class? No. Oh, okay. We are in the online micro. But I sent out an announcement to you guys about micro class yesterday. But I think in that announcement, I made the comment about tests and how tests are worth so much more. Did I send that out to y'all? What you said? I sent something like that to online test too. Okay, good. Y'all worried about it? Okay, so great. All right, it's fine. Because tests do matter. They do. You have to come in prepared for those. We can have off days with some of these quizzes that don't count as much, and some of them are going to be dropped, and we can kind of have off days, but days that tests are, just be prepared. Don't be anxious, but just be prepared. Being prepared, can that take your anxiety levels down? Yes. All right, so had I talked about kwashiorkor? Yeah, I talked about that, and we were talking about red blood cells, right? How long do red blood cells stay in our system? They circulate around for about 120 days, we said, and then every given day we're losing really thousands of red blood cells that are old and worn out. And this is why I think I wanted to start with this today. This is why when you give a unit of blood, and some of you could raise your hands and say you've given a unit, they don't give that unit whole to anybody. They take that unit, whether it's American Heart or Red Cross or whoever you're giving it that unit to, and it's really a great thing to donate blood. They're going to take that unit and they're going to separate it by components. And y'all told me that when you spin, just using centrifugal force, when you spin blood down, the cells go to the bottom and hack down to the bottom. The red cells go to the bottom. There's a Buffy code. It's called a Buffy code. It's going to have the white cells and the platelets. It's called a Buffy code, and when you look at it, it looks white. Even to your naked eye, gross anatomy, it looks white. Why does it look white? Because there's so many white blood cells there together. You can actually see they look white. Do y'all know what pus is? But everybody knows what pus is, don't you? You've seen pus. What does it look like? White. Kind of looks white, sometimes kind of grayish white, and it's, whatever. And sometimes it's thicker than other times, but it looks white. You know why it looks white? Because there's so many white cells in there. White blood cells are microscopic individually, but when there's enough of them together, they will appear white to you. So that Buffy coat has white cells and platelets. And then you said the liquid part of blood is called what? Plasma. So when you give a unit of blood, it gets separated by components. The packed red cells, they're called packed red cells, get put into their own little container. And they have to be used usually within 60 days. Why 60 days? 90 days is the outside. And some blood centers won't go to 90 days. But why would 60 or 90 days be the outside limit? What'd you say?
You have a time for the other person that's receiving it.
Yeah, so here's the thing. When you gave a unit of blood, some of those cells were actually dying that day.
Yeah.
They were going to go that day. But some of them would be kind of new. So you hope if you give those packed red blood cells you try to within 60 days. And our centers that handle blood products, we have almost zero waste because they're so good at knowing where blood is needed, getting blood sent that it's needed to, so almost no blood goes to waste. And so kudos for them. It can go up to 90 days, but you understand that you don't want it to go much longer than that because those red cells aren't going to be functioning. So when you give them to somebody, it's not going to do them much good after that time. So they try to give them, within that time. The Buffy coat that has the white blood cells and the platelets, it gets irradiated because you can't give anybody your white blood cells. Because guess what the job of your white blood cells are? To protect you and attack anything that's foreign. So you have to kill them. But the platelets have to be used usually within 72 hours. Why? Because platelets only live for about 96 plus hours. So those platelets have to be given in a quick order. We said platelets are really just little partial cells. They're only little pieces of cells, still acting as endocrine cells, but little pieces of cells that don't stay in your system very long. So those platelets have to be given quickly. The plasma is going to be frozen. And that plasma can be frozen up to a year before you give that, before that's given, which is nice. And y'all have heard of it. You've heard of fresh frozen plasma, haven't you? Or have you ever heard of that? Okay, so please keep in mind that when you talk about transfusions, you're usually talking about packed red blood cells. So if you've ever heard that somebody had a transfusion, they didn't get somebody's whole blood. They got packed red blood cells. If you've ever heard of platelets, that you'll hear it called that they were given platelets, or they were given FFP, fresh frozen plasma. But when you hear about a transfusion, what are they getting? And you do need to know this for something I'm about to talk about in a little bit. What are they getting? They're just getting those packed red blood cells. That's what they're getting. All right. And that's going to be important for us in a minute.
So that would be really thick.
It is really thick. It is really thick, but they're given, there's a preservative in there that's keeping them from clumping. So, yeah. All right, now, hemoglobin, I had told you, is this molecule, is this protein that is going to actually transport oxygen, right? So it's going to transport oxygen to our tissues. And that's why the red blood cells are so good at doing this, is because predominantly this is their protein that they have. I do want you to know for one hemoglobin molecule, which by the way, there are about 280 million of them in a red blood cell. But for one, it's got these heme groups that we know in the center is a what molecule? Can y'all see it from there? It's Fe. Do y'all know what that stands for? Iron. So if you didn't have iron, could you make that? And if you can't make, if your red cells don't have that, then are they delivering oxygen the way they should? No. So if I were to ask you all, and I have this all the time, y'all know what the definition for anemia means. What is it? A low red blood cell count. Sometimes I'll ask people, define anemia, and they'll say low iron levels. Is that anemia?
No.
No, that is not. What is that? That's one cause, potential cause of anemia, if you will, but that's not defining anemia, is it? So we understand that too, there are other components that are also needed. So we've got to have, does everybody understand what I'm saying talking about that? Okay. So we know that there are other components that are needed. We need vitamin B12 and folic acid. We need other things to be able to make these red cells at the rate that we need to make them. And so there are many different causes for anemia. Could you have kidney disease that leads to anemia? Yes. And so it might have nothing to do with iron, nothing to do with B12. It might have nothing to do with any of that. You could be anemic because your kidneys are failing, because you have diabetes, and your kidneys are failing, and they're not producing erythropoietin, and now you're anemic. Actually, almost everybody that's ever had kidney disease before their kidneys failed, if you were to go back and look at their lab results, you would have seen anemia started. Right? So that makes sense to us that would be the case. I had talked to you all about, maybe I would talk to you all about hematocrit. Normal men have higher than women, had I? Yes. And I told you why, right? It's because of a hormone called, which causes their muscle mass to be greater, and muscles require a lot of what? Oxygen. So this all makes good sense. And so we get this. And I said hemoglobin is about a third of this, and then your red counts, are all need to be kind of within normal ranges. But it was just the hematocrit I talked about that. All right. So then I said to you that I don't know where we stopped. Where did we stop? Oh, did we? Okay. So we kind of gotten through some of this, and do we know what bilirubin is? Yeah. I could have asked all questions about our red blood cell disposal and what bilirubin is. Why is bilirubin? We all have bilirubin in our system because we said we all have red blood cells breaking down at any given time. But it shouldn't be very high because we have functioning livers that produce enzymes that are going to break this down to a substance called bile. Bile is actually produced in the liver and secreted from the liver into our intestines. Some of you, and that's secreted into our intestines. Some of you, actually all of you, have probably had, all of us, have had such violent vomiting in our history of having something, whatever it was, whether it was a virus or whether it was food poisoning, that we vomited so much that we lost all the contents of the stomach, and then we were having contents of the intestines coming off, bile. It's a yellowish, greenish, kind of caustic sort of substance, because it shouldn't be coming this way. It has a big function going the other way, though, into the intestines. It's vital for fat absorption, emulsification and fat absorption. So how wonderful. We're breaking down these red cells. We're using the amino acids to build new proteins. We're breaking down the heme part, and yes, our liver is producing these enzymes that break down that heme part that goes through bilirubin down to bile, and then bile can be used for nutrition. We're just perfect recycling machines when everything's working the way it's supposed to be working, right? But we said we want it breaking down to bile because if it doesn't, bilirubin starts to build up and it's neurotoxic. And that's a problem. It's neurotoxic, and we will see a sign of it when it's starting to build up. We can actually see a sign, which means that it's visible. We can sort of measure it. What's the sign we'll see when somebody's got too much bilirubin? They're turning yellow or orangey in certain areas, especially the sclera, the whites of the eyes, right? And that can be a real indicator of liver disease. Now, do we know what the liver disease is yet? No, we have to do further testing, because are there a lot of things that can cause liver disease? Name some things that can cause liver disease. Well, yeah, so alcoholism. So alcohol is a legal drug, isn't it? So it's a legal drug, so we know our legal drugs are the most abused drugs. Believe it or not, caffeine is. Where's mine? Caffeine, nicotine, alcohol, the most abused drugs. But are there over-the-counter drugs too that can cause liver problems? What? Ibuprofen, acetaminophen, many of the over-the-counter drugs, because our liver is a filter. It filters our blood. So many things are being concentrated in the liver and kidneys. And so you have to think about that could happen. What are some other things that can damage your liver? There are viruses that can attack the liver. Hepatitis A virus, hepatitis B virus, hepatitis C virus. There's a D and an E, and actually they've been designated by letters of the alphabet, and there are dozens of them. But the ones we hear about most is hepatitis A, B, and C. Y'all have all heard of those viruses, haven't you? We named them hepatitis A, B, C, and the other viruses because they cause inflammation of the liver, and the cells in the liver are known as hepatocytes, right? Hepatocytes are liver cells. So, all right, so this is just basic medical terminology, but half the battle is knowing the language, isn't it? So no big words, just words you need to break down. And don't ever give up on words either. Okay. So now, I went a little bit, what did they say? Around going to get to this, whatever. But anyway, and so we're back. And this is sort of where we stopped off, I think. In polycythemia, when we look at this, it means a lot, because poly means many, right? Multiple, many. Cells, site, in the bloodstream. Anemia always means in the bloodstream. I don't care where you see that, it means in the bloodstream, doesn't it? Right. So we learn these prefixes, suffixes, and root words, and then we got them, right? And it's going to make things easier. So there's a couple of different causes of polycythemia. Primary polycythemia, then we think about things that can cause secondary polycythemia. Guys, we don't hear about disease. Disease is considered to be anything that takes you out of what? Homeostasis. When y'all hear about disease, you'll hear about disease listed as like the primary disease. And then you'll hear like people can have primary hypertension, which means what? What's hypertension? I'm trying to do something you know, and then I'll talk. It means you have high blood pressure. And if you have primary hypertension, that's your disease. But there's also secondary hypertension, which means that you are now have high blood pressure because of something else you had. What's one of the most common causes of secondary hypertension? And actually, it's an epidemic in the world today, not just in our country, but even in developing countries. Diabetes. Diabetes mellitus is one of the leading causes of secondary hypertension. So you get what I'm saying. So secondary, just whenever you're talking about that with any disease, it just means that now you have this because of another disease that you have. It's now you've got this going on with it. But now we're talking about polycythemia. Primary polycythemia means that you have cancers of that erythrocytic line in the stem cells, that erythrocytic line. So guys, I had told you that women want to have a hematocrit from 36 to about 42. And y'all are thinking, okay, so that's a little bit over a third of whole blood should be these red cells that are contributing a lot to the thickness of blood. So when you think about 40, let's say somebody's got a normal hematocrit of 40%, and then all of a sudden it goes up to 80%, what does that blood look like? It looks like sludge. Can you live long with that? You couldn't. So treatment has to start right away, and they really are, so this is not good because this puts you then at risk for stroke, embolisms, right, and heart attacks. So not to mention that you're not breathing, and this is like you should be. So this is a very serious thing. And it's pretty rare, thank goodness. Primary polycythemia is pretty rare. But let me tell you what's not rare, and that's secondary polycythemia. This isn't rare at all, and it should make sense to you when I talk to you about these conditions, why your red cell count would go up or appear to be up. Guys, if you're dehydrated, what's that going to affect in your bloodstream? Which component of whole blood? if you're dehydrated. It's going to affect the plasma, and the plasma content's going to go up. So in proportion, what does it appear has gone up? The red cell count. Do you get that? In this country, where we're considered to have a water-rich country. God, especially lately. Okay, but no, we really are. There are many people living in areas where water is a limited resource. I mean, it's limited to them and their lifestyles and whatever. But in this country, we're a water-rich country, and it's thought that a fourth of our population at any given time are dehydrated. It really is. And my emergency people, tech people and paramedics, they know that a lot of their calls are going to be related to just simple dehydration. And you think to yourself, well, drink something, fool. No, you don't think that. But guess what happens? No, excuse me, I really don't think that. Sometimes you do. But here you go, no. So, but here's the thing. And we all are foolish. Because have you felt thirsty before? If you ever had the sensation of feeling thirsty, your body is already struggling with dehydration. Your body is already trying to compensate for dehydration. So really, we should be hydrating ourselves frequently. And here's the thing, too, we know about kids. Little kids don't understand what you mean when you ask them, are you thirsty? They don't know what that means. That's like telling them that someone's coming to visit them tomorrow. What is the concept of tomorrow for a little kid? They don't know what that means, do they? Until they get tested. So in asking, or even asking, does your head hurt? They don't know things like this. And little kids, instead, how will you know that they might be thirsty?
They ask
How would you say? Well, sometimes they will be asking for drinks. If they're asking for drinks, they're dehydrated. But a lot of times, even before then, and I'm even talking about even a little bit younger, where they actually, if you're really watching, their urinary output might be going down because they're dehydrated, so they're not making urine. When they cry, there are no tears, but they also are their moods are affected by it, aren't they? So if they're fussy and you think they're being a brat, it could be because you're not paying attention, but they're thirsty. Right? Not that you ever thought of your kids as being brats. But I'm just saying, that's how they will exhibit that. They will exhibit it in different ways we don't really know. So this is why it's really important that people may watch and help kids, toddlers especially. They really can't thermoregulate either. Babies can't thermoregulate. They can't really tell you. So what you do is you just make sure that they are routinely being given enough fluids. You can have fluid overload. I'm not saying go crazy with it, but yeah. So dehydration, yes.
Is it bad that like every now and then, not all the time, I'll feel like I'm about to pass out if I don't like drink a soda?
Yeah. So well, the soda part's bad, and that you would get to that point is bad. So we had a conversation about drinks, sugar things. I see you got your water there, Holmes.
Yeah.
Okay. Yeah, because if you're feeling that, your body is already struggling to maintain all of this. And see, it even affects how blood is moving through your system because this is making it harder on the heart, it's making it harder on the lungs. All of that's already being affected. So dehydration can give you a transient, it's not going to stay, but for a bit you have a transient secondary polycythemia. So absolutely. Now, look, I need y'all to hear about emphysema too. What is emphysema? It's a lung disease. But what is it? What is emphysema? It is one of the major causes of chronic obstructive pulmonary disease. So when somebody has emphysema, they can't bring oxygen to their blood into their bloodstream because they are losing alveolar spaces. You have these little alveoli. This is an alveolar sac of little individual alveoli. And as you breathe in, oxygen oxygen, which is part of the atmospheric air, comes into these sacs. And for oxygen to move into the bloodstream, by the way, each of these little alveoli are going to have capillary blood vessels surrounding them, and red blood cells are moving through. So for oxygen to move across and CO2 to move out of the bloodstream into the alveoli, you have to have a surface membrane area for that to happen. But people with emphysema, when they breathe in, it's because of smoking. On rare, less than 1% of people with emphysema, I've never seen, and I was at UVA where everybody came that had something crazy. I've never seen, everybody I knew had emphysema was because of smoking. Smoking pops this alveoli. And now this is pop, there's like a bubble would pop on soap, you know, bubbles will have on soap, bubbles start to pop. So now when they breathe in, air gets trapped right here, putting pressure on this next one, and it pops. And then the next one pops, meaning more air has a chance to get in, put pressure on, popping more, and you've lost surface area. So now with each breath in, you only have this amount of chance for oxygen to move in. So you're hypoxic, meaning hypoxemia, which is low oxygen in the bloodstream. And the kidneys are measuring your oxygen levels, aren't they? So what are your kidneys sending out whenever they get low oxygen levels? Erythropoietin. Erythropoietin's making you make more red blood cells. So more red blood cells are coming here, thickening up the blood, and it really has nothing to do with that. It has to do with that you're trapping air. Emphysema is a progressive terminal diagnosis. What does that mean? It means that if somebody's been diagnosed with emphysema, and it's a true diagnosis, not just somebody throwing the word out. If somebody's been diagnosed with emphysema, it means that the emphysema is going to get worse. And if something doesn't kill them first, it will. It's a progressive terminal diagnosis. The thing about emphysema is that it's not about them not being able to bring air in, is that the air is getting trapped. They need to get the air out. They're suffocating in air. They're becoming fish on land because the air isn't, and you'll see them do it. The air isn't doing it for them.
So what is COPD?
See, this is one COPD. The other major cause of COPD is asthma, but asthma isn't this. Asthma are the conducting airways get constricted and reactive. So the lumen, the opening of the airways because of reactants in the air, the lumen's closed down. So air is being restricted in how it comes in. It can go out. And that feels horrible too, doesn't it? Every single asthmatic attack is a life-threatening attack. It's life-threatening. So that feels horrible too because it's obstructing air, but it's very different from emphysema. Emphysema, you don't have an attack of emphysema and get over it. It's progressive and it's there. And you are chronically having it, and it causes your kidneys are doing what they're supposed to do. In cases of low oxygen, they're producing more red blood cells. But did you really need more red blood cells? Was that really the problem? So now blood is thickened, which is putting a burden on the heart. And here is what I'm going to say to y'all, and I don't mean this because I know some of you all, because it's so common, emphysema. I know you know people who died from emphysema. Would I be right in saying that? And guess what, folks? I have had that happen to me too, my family. But here's what I want to tell you. Usually they're not going to die from suffocating. They're going to die because of a heart attack. Because their hearts had to struggle for so long because their lungs have been failing. that they have a heart attack before they can suffocate. If you've ever watched somebody get end-stage emphysema, it will be the worst death that you will be witnessing because they will suffocate. And they'll suffocate dozens of times a day, and then they'll get their breath back. They'll pass completely out, lose all body function. They sometimes defecate. They pass completely out, wringing up sweat. And then the autonomic nervous system sort of gets back control. And they'll do that a dozen times a day for the last year of their life. And when I tell you it's the worst death you'll watch, it will be, you will remember me saying this, it is the worst death you'll see. But usually they don't die from that. Usually they're going to die because they have a heart attack before they get to that point. Guess what it's caused from? Smoking. Guess what that means? It's preventable. It's preventable. But emphysema, you'll often see them be polycythemic, and it's secondary because of that. Transiently, if we go to higher altitudes, what do we know happens to the oxygen content? It goes down. So if we suddenly go to higher altitudes, can this put a burden on our respiratory system, which is then putting a burden on our heart? It's why you see people like professional athletes when they're going to play it, like, you know, if they're from seaboard regions like DC or whatever, and they're going to Colorado, they go days earlier to condition to get that happening. It's why you see even trained and athletes doing that Tour de France thing when they're in the mountains, having heart attacks and dying. Because even though they're trained athletes, changing altitude, it's a risk, isn't it? It's a big risk. So so that can actually happen, and that can put like a quick, immediate burden on the heart, and some people's hearts won't take it. So you see that this is secondary polycythemia. This maybe the saddest part up here is the dehydration, because is that easily corrected? That's easily corrected. It's just that there's some people who won't be able to tell you because they're too little, you know, so you would want to know that. All right. The dangers of this, I've just told you. Does everybody know what an embolism is versus a thrombosis?
I do not. That's a first.
What'd you say?
I don't.
Okay, so thrombosis, I want you to write down the word thrombosis versus embolism. Thrombosis is a blood clot. Thrombosis is a blood clot in an unbroken vessel. So have y'all ever heard of DVTs, deep vein thrombosis? It means that you can even have an injury. You know, you usually don't think about clots forming unless you have an injury and you needed the clot, right? But you haven't even had an injury. And you have this blood clot that's formed in a vessel. That's a thrombosis. Now, an embolism is a moving blood clot. It's one that's moving. So if that blood clot breaks off from that where it's formed and it starts to move, where could it get to? The heart. And you guys, usually that means immediate death. If it gets past the right heart side of the heart to the lungs, again, a pulmonary embolism often means immediate death. If you,
It traveled from her legs to her lungs.
I'm so sorry, Tiara, because it's horrible, it's horrific. But she knew she had the deep vein thrombosis. She knew
She did know.
She did.
I remember talking to her that night. She was like, my legs are hurting so
and
bad.
that's a sign.
And she passed away the next day and traveled from her legs to her lungs.
Now look, guys, if y'all hear somebody, I'm so sorry, Tiara, because that really is a sudden death, and it's really horrible. But if just because you hear about somebody having leg pain, though, don't necessarily think deep vein thrombosis. But is it a sign that it could be? And especially if you've got somebody who has who isn't very active, and somebody who's sitting. This is why we need to be up and moving, don't we? Because it can prevent deep vein thrombosis sometimes. Sometimes you can't prevent them. Some people just can have them. But people who survive, people can survive deep vein thrombosis by treatment, getting treatment. Because they will give treatment that is going to burst the clot and try to dissolve the clot before it would move. They can put in the veins nets that can actually catch them too. So there's treatment for deep vein thrombosis if you know you had one. But if you don't, and it led to a pulmonary embolism or went to the heart, it's usually sudden death. It's usually sudden. And if you know anybody who ever survived one, they're really lucky people because they're lucky. Young women get told, birth contraceptions that include the hormone contraceptions, the pill, and they took the patches off because of this market. But this can actually increase women's risk of having embolisms, especially if they smoke. You are never supposed to do hormone therapy if you smoke. And you get told that, but I don't think too many young women are listening to that, right? But you get told don't do that. Smoking. What's the positive with smoking? I just talked about the emphysema and that you could have blood clots that would kill you. But what's the positive with smoking? No. Positive. So stress should be addressed.
Well, I don't know. I know people that say they.
Yes, there's people self-test. So that's why some people say they do it. I had a young woman in this class one time that was pregnant, and she said her doctor told her she needed to smoke because it would make sure that the birth weight of her baby would be small. And that was either a gross lie or what I think it was more of was a gross misinterpretation of what the physician said. Because I know I get misinterpreted in here, and I know people misquote me because I've heard them say things, and I know they do. But she said it with such a straight face that I think that's really truly how she interpreted that. But that smoking is a teratogen. It is harmful to a fetus. And there's no ifs or ands or buts, and there is no positive thing for smoking. It is none. None. But it is a legal drug. And so legal drugs we have in our society because if they're legal, there's going to be more abuse because they're more recommended. So something to think about. Anyway, but there's no positive in smoking. Who needs a cigarette? Let's take a 10-minute break. Let's take a 10-minute break. The reason. All right. So, I'm going to stick to my story. Okay. So polycythemia we know about. So you can have too many red cells, but then you can have too few, right? So too few. Everybody's good with me. So you all would know anemia is not a definitive diagnosis. It's just telling you that for some reason you don't have enough red blood cells and or hemoglobin. Usually they go hand in hand. You got to figure out why. So we said kidney failure, iron deficiency, inadequate B12, which is pernicious anemia. These two can sometimes be just because stomachs are not functioning. We had talked about you have to have enough stomach acid to be able to change the iron to an absorbable form. You also have to have enough intrinsic factor that the stomach provides. And this is really a hormone-like molecule that is going to allow for us to absorb B12 when we eat it. So if you don't have that, then you're going to have pernicious anemia. Hypoplastic anemia is going to be just a slowing down of erythropoiesis, but what is really scary is aplastic anemia diagnosis, which means that your red cells are no longer, you're not making any red blood cells. This is a serious, potentially fatal condition. So aplastic anemia, it's rare, but it can actually happen. Hemorrhaging can cause anemias. Is hemorrhaging always obvious, did we say? No, sometimes it's not at all. So people need to figure that out if they have a GI bleed somewhere that might just be a slow bleed that's causing anemias. Could you have a problem with menstrual flow that you really truly are hemorrhaging? Mm-hmm. Yeah, no, that's not normal though. That's a problem. Okay, so yeah, we said that. And then hemolytic. What does lysis mean? It means to split, to lyse, to split. It means that for some reason your red cells are lysing, they're splitting, hemolytic anemias. And let me tell you when that typically happens. It's because of infectious diseases. So infection Like infections that we think of that can do this are those kind of deadly infections that can take you out of this world, right? E. coli, certain E. coli can do this, certain streptococci can do this, but they can cause what are referred to as hemolytic anemias. So again, this is usually because of an infectious process that's happening. All right, so many different causes for a low red cell or hemoglobin count. And what you want to realize is if you're not getting enough oxygen, hypoxia, it's going to lead potentially to early death to your tissues. And we call that what? Necrosis. We learned that in AMP1. We said that death, early pathological death to a tissue is referred to as necrosis. So this is what this could set you up for. Blood osmolarity is changing. So because your blood is now thinner, you know, we had this thing to say thinner, is the viscosity is changing. This can lead to edema in the tissues because that blood osmolarity is lower than what the tissue fluids are. So fluid will move out. Can it also even lead to hypovolemia, which is hypovolemia? It's hypovolemia with a V, volume. Hypo means low, volume in the bloodstream is the most common cause of shock. So shock is dangerously low blood pressure. Dangerously low blood pressure. So hypovolemic shock is the most common cause of shock. Things that can lead to that are going to be dehydration is number one. And then hemorrhaging is another thing. And so anyway, and this can also kind of lead to that because fluid will be moving out. What's the heart having to do if blood's too thin? I told you, just like it had to be just right, didn't it? Because the heart's a muscle. So if blood's too thin, it's having to work so hard. So the heart's going to be speeding up. It's going to be trying to beat harder. And it can actually lead to cardiac arrest, where the system just gets a signal for cardiac arrest. So I want to let you know about a very common, it's the most common inherited disorder of darker tone people. It's called sickle cell disease. This is an inherited defect of that hemoglobin molecule. And I want you to know that it's an autosomal recessive disorder. An autosomal recessive disorder means what? What do y'all remember from AMP1 and
Parents have to be carriers of the trait.
right? So if it's autosomal, it means that the trait is somewhere in the first to the 22nd pair of chromosomes. Both parents contribute to every one of those autosomal traits, don't they? Because you get one of those chromosomes from your mom, and those pairs, and you get one from your dad. Is that right? And potentially for the same trait. So what it means when it says it's autosomal recessive, it means that your mom gave you the recessive information for hemoglobin. I'll just use the letter H for hemoglobin. And your dad had to also give you that same information, recessive. So you are homozygous recessive, and it means you have sickle cell disease. Is that right? Before modern medicine, sicklers died early. Before modern medicine. Because every sickle crisis is a potentially life-threatening crisis. And before modern medicine, they died early. And sicklers still die during crisis, even with modern medicine, don't they? But with modern medicine, you try to prevent crisis from happening, getting to that state, prevent the severity of crisis so that it won't have long-lasting effects. And now people with sickle disease, if all of that is taken care of, they can live normal length lifespans, and that's to celebrate, isn't it? You might think that this particular trait, you might wonder, well, since they used to die early, how did they ever have children and pass the trait on? How did it stay in the population? But what we said is a lot of the area of our world, we live in a very small global world, world. A lot of the area in our world, including even in our country, guys, we've had malaria outbreaks heavily. Where we see it mostly, though, central regions of Africa, some parts of the Middle East and South America, near the equatorial regions, we see malaria outbreaks. Malaria is a disease that's caused from a protozoa. It's actually really attractive little protozoa called Plasmodium. And Plasmodium is this little protozoa that spends some of its life in mosquitoes and some of its life in human red blood cells. So we could absolutely get rid of malaria if we got rid of all the people. I was going to say that, but I think it's funny. Okay, but so we're not going to get rid of the people, are we? But then you think to yourself, well, we could just get rid of the mosquitoes. Is that easier said than done? Yeah. Yeah, it's a lot easier said than done. By the way, more than 1 million people die annually from malaria. Y'all, you can't even get your head around that number, can you? That's a hard thing to get your head around, that many people are dying every year from malaria. The people who live in these equatorial regions, when they've inherited from their parents absolutely normal recipes for hemoglobin. Their red blood cells couldn't be any healthier. And guess what loves them? That malarial parasite, that protozoa. So they're at risk for dying from malaria. But the people who are carriers of the trait, they have normal hemoglobin, so they don't have sickle cell. But they have the recipe that's abnormal, that tweaks their red cells just slightly bit. So that parasite, that little protozoa, doesn't like their blood. And I'm taking a few little liberties here because some of these protozoa, different species of the Plasmodium, are more deadly than others. But anyway, this person gets to live. And because they get to live, what do they potentially get to pass on? This trait. So this is how this trait has stayed in the population in such high numbers. It's the most, because it offers, if you are heterozygous for it, it offers some immunity to malaria if you live in these regions. So that's why it has stayed in the populations. But anyway, yeah.
I've never seen it.
Okay, so what sickle cell is, and I'll remind me to get some slides out when y'all are looking at your own blood films of people who are in sickle crisis. When they take their blood, you'll see what their red cells look like. Our red blood cells are said to be what kind of shape? Disc, donut-y shape. And our red blood cells, where nutrients are exchanged, that's happening at what vascular level? I should have asked all that today. Is that going to be on your test for cardiovascular system? I can guarantee those questions. Okay, they're going to be on there. I guarantee them to y'all now. If they're not on there, remind me, I'll give you extra points. Okay, they're on there. All right, look. So you're thinking about normal red blood cells. And capillary blood vessels are microscopic. They're so tiny, these little capillary beds where all that nutrient exchange and water exchange is happening, that red blood cells have to go through them single file. Red blood cells are really squishy and malleable, and they can change shape, and they can squeeze through, they can pop through places that are bendy and whatever. Do you get what I'm saying? People who have sickle cell disease, when they're in a crisis, and stress can cause the crisis, low oxygen, almost anything can bring on a crisis. It's not hard. Sometimes they don't even know what brings on the crisis. But what happens is the red cell that should be, moving through these capillaries, sickle and get harder. So they're trying to move through the vessels, and they're not moving through. Blood is not flowing the way that it should be flowing. And if y'all have ever had a Charlie horse or cramp or something, where blood is not getting through to the muscles and it's hurting, that's in one little site. I want you to think about it, that feeling all over. All over. If you've ever been in labor, without your kids, you know what those contractions feel like, right? There's the pain from childbirth. There's some pain with the stretching and a little bit of it. That's called that ring on fire thing, but that's nothing compared to the contractions, right? Those of you who've been there, done that. The contractions, that is happening because oxygen is not getting to the mitochondria. The pains of contraction, child labor. are happening because oxygen is being impeded to the tissues. So when you think about that pain of contraction that's just happening in your uterus, I want you to think about a sickler in crisis, and this is happening everywhere. I think I told y'all this. 2 patients that I remember, and I've seen a lot of sicklers in crisis, but true pain is a sickler in crisis. That's true pain, folks. It really is. And so I don't want anybody who's ever going to treat a sickler in crisis to ever let anybody else on the health team tell you they're drug seeking. Or, you know, they're just in here because they want more drugs. Or they're just in here. Don't you let people do that to tell you that. You show them their blood film and what it looks like when they're in crisis. Their blood's not moving through their capillary beds. And it's not just in one location like a uterus or a calf muscle. It's all throughout.
How long does the crisis last?
Well, it just depends on, you know, it just depends on how quickly they can get to medicine and how medicine takes over, and you know, how they can try to reverse it. And I can't tell you exactly what steps they take. Has anybody been that they've seen that recently? It's been so long since I've been in the ER when they come in. I don't know what the newest. Does anybody know somebody with sickle cell disease that they've known somebody with a crisis? Do you know what they do immediately now? Do you know what they get? They get pain relief, because anybody who knows they need it. You know, they get that, but that's not helping a crisis, is it? That's helping them not know they're in a crisis. That's helping them just to be able to not know. But they also, I don't know what meds they're given to help reverse these things. And so it just depends. But it's sort of like an asthmatic attack. Every crisis event is a life-threatening event. It's potentially life-threatening. So this is sickle cell disease. So it's happening to every organ system. The thing is, when all that's happening, the kidneys are being damaged, the filters in the kidneys, the heart, joints, everywhere. Every organ system is being affected by this. All right, so blood types. I want to tell you all, I want to do my own slides. I know y'all think sometimes when I'm doing my own slides, you're thinking, oh my God, will you go back to the PowerPoint? But I'm doing my slides on this. My own slide on this, talking to you about blood typing. Has everybody here heard of like ABO blood typing, right? How many of you know your blood type? Raise your hands high. I think. Okay, so quite a few of you know your blood type. You're going to have the opportunity to do your blood typing today in lab when you make your blood film, okay? If you want to. But anyway, I want you all to know exactly what blood typing is. There's certain situations that happen in the medical field where patients are at high risk for medical professionals killing them. Drug dosage errors, right? Is that right? And you can say, nurses, all you want to, that it was the doctor's order or it was the pharmacy sent the wrong thing. You can say all you want to. Who's the executioner? Nurses. Would you say, Charlotte?
And nurse, she gave it, she did it.
Well, and it's really unfortunate, and I'm glad that Charlotte, you know, because it's true. The nurses are the executioners. And so I have had my students tell me, and Charlotte, you've been working with nurse. I wanted to just ask you, I've had my students tell me that RNs on the floor tell them, oh, just get through that drug dosage stuff because you're never going to really have to do it. The pharmacy does it. Have you heard RNs say that? Yeah, so guys, yeah, depending on how much time you have to talk to them, let them know that, no, that's not true. We're the executioners. We're going to be the ones that are pushing the drug. So when we're pushing that drug, it's on me, it's on you, right? It's on you. So in drug dosage is not a difficult thing, but you have to stay up to date. Math is so weird, isn't it? Because if you don't practice it, will you lose it? Yeah, so you need to stay practicing drug dosage. Drug dosage errors, cross-matching errors, and this is going to be ugly when this happens. And insulin. Giving somebody insulin and then not checking their blood glucose levels. Because what will insulin do to blood glucose levels? I had a couple people not get this right, but what will they do? It will drop it. So what must you do? Be checking those blood glucose levels. What kills patient diabetics quicker? High glucose levels or an insulin shock?
Insulin shock.
Insulin shock. Insulin is a serious medication. It drops blood glucose levels. If they drop so below, a certain level, that person will look like they've gone to sleep, right? But they might not be asleep. They might be in what? A coma, an insulin shock coma. Insulin's a serious drug. Transfusion problems. One of the last ones that made national news happened at Duke. And it was an 18-year-old girl who it happened to. So guys, I don't want you to, let me just tell you which is so wrong. Sometimes local places like small town hospitals and stuff can get a bad name, because you'll always hear the bad first, won't you? You don't get to hear the good, but you'll hear the bad first. But I don't care where you are. I don't care if you're at Duke, if you're at UVA, if you're at BCU. I don't care where you are, or if you're in Farmville, or if you're in South Boston, or South Hill. They're good people out there working, and there will be some bad ones. So I don't care where you are. That's the case. But what you can do is control what you've got in your own little world. So you can be checking up on the doctor's prescription. You can check that the pharmacy said the right thing. You can be careful of these blood products that you're given. How many of you have been around somebody who's been given a blood product when they've been given? Have you been there as a patient or family? You would. So you know that when you get packed red blood cells, the person who goes to the lab to get them, they don't just initial picking them up. They write their whole name, their whole entire position, and a phone number. And then you pick up the product. Then you take it to the patient. And that patient has an entire another band, not just their hospital band, but an entire another band related to this. Why do you think they go through all this, by the way? Because you can kill somebody, okay? So they have an entire other band that you're checking. You're making sure you checked it to the unit, because the lab has cross-matched it if everything's working like it. So they cross-matched it. They've done what they needed to do, but you're making sure. Then you're not acting, squirrely about it. But as you started, you don't get to leave them, do you? No. So you're watching and you're just talking about whatever because you don't want to make them nervous. But if their eyebrow starts to twitch, or their upper lip starts to sweat, or they start scratching anywhere, what do? You stop it right away. And then you go into the protocol of doing something for error and a cross match, and you hope you haven't killed them in that time. Because they may be just a dead person playing, and they don't know it. So, let me tell you what I see, and I see it all the time. Medical professionals saying, oh, but I thought that was the universal donor so-and-so, or that was the universal recipient, or I thought, well, the chart I memorized said that this person could get this product. And what's wrong about that already? They memorized something and didn't understand what was going on. So I want to give this to y'all in a way that you will understand it, and it's not hard. So it's not. I don't want you memorizing a little chart, because you might think to yourself, I just would rather memorize what blood type can get what. Because that little chart's not very big. But people die because of this. So know what's going on. You ready? Mm-hmm. All right. So let me tell you about blood typing. There's something called a major blood typing. Major blood typing. And that's the ABO blood typing. The ABO blood typing. A, B, and O. Now, this is the major blood typing system, but we also have minor blood typing systems too, with antigens. But anyway, I just want you to know this is the one that causes the most trouble in patients that have transfusion reactions. So let's understand what it means when you know someone's blood type. And let's understand what it means when someone might have a potential reaction, why they're having the reaction. Okay, let's understand it, because then it will never be something we have to memorize, right? All right, so I need y'all to know two things before I start. This is representing 4 different people's veins, vessels, and this is a red blood cell. So this is one person this is one person's red cell traveling through their veins. This is another person traveling through their veins. This is another person, and it's red blood cells traveling through the veins, and you get what I'm saying. But before I talk to you about that, I need you to write down 2 types of proteins. I want you to write down antigen, and these are both proteins. I want you to write down the term antigen, and I want you to write down the term antibody. Are these molecules proteins? Did I just tell you that?
Yes.
They're proteins, and now I need you to know where we find these proteins in a person. Now, your textbook in chemistry people will talk about agglutinins and agglutinogens. You'll never hear those words. So here's what I want you to know. Antigen, and what was the other one? All right, look. Because that's what we inherit. Now, let me say this. Antigens, when you're talking about ABO blood typing, antigens will be found on the red blood cell membranes. If they're present, they will be there. Will you need to know that?
Yes.
Yes. Antibodies, if present, will be found in the plasma. Do we know what plasma is?
Yes.
What is plasma?
You see them?
It's the fluid, the extracellular fluid blood. So again, do you need to know those 2 things? All right. These are proteins. So let me ask you something. Where do you know you get the recipes for your proteins? From your DNA that you got from where? You got it from your parents, these particular ones. You know you got this, you're going to have a recipe or not. Or not. Is that right? So what did I tell you this is representing right here? This is representing what? A potential person. And this is one of their what? And this person might or might not have a what on their red blood cell membranes? Not antibodies. Won't be on the red blood cell membranes. Antigens. Is that right? So I want you to know that if this person inherits a little recipe that gives them, oh, I wish this was actually writing where I was drawing. It would make it much easier. A little recipe for a protein that looks that shape, that has that shape, that very specific shape. This person is said to be type A. If this person, did I say this is a different person?
Yes.
If this person has a little protein that has a antigen that has this shape on its red blood cell membranes, they're called a type B person, blood type B person. Are y'all good with this so far? You're good with this so far? No kidding? All right. Now this represents another person. Is that right? Suppose this person has these little proteins and these little proteins. What are the proteins called? Do you need to know that?
Yes.
Yes. What would this person be? Blood type B. This person's called an AB person. Blood type? Are you sure? Yeah. And how about though, if this little person has 0 antigens? 0 antigens. They're O? They're blood type O? So you're telling me if a person has blood type O, they don't have any A antigens nor B antigens? Is that what you said?
That's correct.
That's correct. Is that tough so far? That doesn't seem too tough so far, does it? Does it? All right. Now, but we know, usually when we're talking about transfusions, what is the patient? Think of these as 4 patients. These are 4 different patients you've got. That one's in room 12, that one's in room, you see what I'm saying? 4 different people. When we talk about blood transfusions, what are your patients actually getting? The red blood cells. That's what they're getting, the packed red blood cells, right? Let me tell you what kills people that have transfusion reactions that you can't stop, and it ends up, you know, being bad. It's not the packed cells you get on. It's the reaction of what's in their plasma to the packed cells. So let me say this to you guys. Before you ever give a blood product to a patient, you need to ask, because you're going to see their blood type. You need to ask yourself, though, what is in my patient's plasma? What did I tell you is the protein you have to realize might be in their plasma? Antibodies. Now, let me say this about antibodies. This is going to seem like antibodies are doing bad things. But antibodies aren't doing bad things. There are very few that are called naturally occurring antibodies, And the ABO antibodies are naturally occurring, meaning you're going to have these a few months after you're born. They're just going to show up. Where are they going to be found when they show up? And your blood plasma. They're going to be circulating around in that blood plasma. And I don't want you to think of antibodies as being bad, but let me tell you, because they're not, they're good. They're the reason we get to survive out of infancy, is because we have a lot of antibodies that are protecting us. Let me tell you what antibodies do. This is their job, and I don't care whether you're talking about ABO, naturally occurring antibodies, or you're talking about antibodies that you have against measles or mumps or rubella or whatever. Antibodies are proteins that seek out specific antigens. And when these antibodies seek out specific antigens, you know what they do to them? They destroy them. They annihilate them. They take them out. And they're really good at it. They're really good at it. And these aren't bad things. These are good things. Let me tell you about naturally occurring antibodies that show up in your plasma when you're just a few months old that are related to the ABO blood type. And this is going to be everybody here. A person who has blood type, what is this person's blood type? A. You must remember that they have antibodies against B. So they have circulating this little structure that is absolutely, do you see how that, well, if I could have drawn it right, could hook up to that? Y'all see this thing? So they have an antibody circulating in their plasma against the B antigen. A person who's blood type B, what do you think they have?
Antibodies against A.
They have antibodies against A that have the absolute complementary, oh God, I can't do a complementary shape to a star, but do you get what I'm saying? And these antibodies, if they ever get presented with these antigens, what will they do? They will attack, annihilate, destroy, take them out, won't they? All right. A person who is blood type A and B, they have the A antigen and they have the B antigen. Would they ever make an antibody against A or an antibody against B? No. So guess what? They don't have any antibodies. They have no antibodies. No antibodies. No antibodies in their plasma. How about a person who's blood type O? They have anti-B, and they have what? And they have anti-A. A person who is blood type O have circulating antibodies against this O antigen and they have circulating antibodies against this A antigen. And if you ever presented this person with packed cells that were from an A person, what are they going to do to those packed cells? They're going to attack them. And if there's enough of them present that they're attacking, it's going to shut their kidneys down. And then it's going to cause their vessels to start throwing clots. And you're going to be lucky if you're going to save them. If you ever gave somebody who's blood type O packed cells with somebody who was A or B, they're in trouble. Because what did you ask yourself about your patient before you gave them that? You said, I know their blood type, but what is in their plasma? Because what's doing the damage? The potential antibodies that are in their plasma. Do you all get that? It's the antibodies in your patient's plasma that end up causing the transfusion reactions. So you can't just be thinking, oh, A, they're A, they're B, but in O, like universal donor, sure, I can do. No. You're thinking about things, right? You're thinking about it. What is in my patient's plasma? Are we good? Mm-hmm. All right. Now, there's also something known as being positive or negative. Have you ever heard of that?
Yes.
Somebody's positive or they're negative blood type. That really is inherited completely differently than ABO blood type. ABO major blood typing is the only place you're going to have naturally occurring antibodies. It's the only place you've got naturally occurring antibodies. Typically, you're not going to make an antibody to something until you've been exposed to it. And when you've been exposed to it, then can you form an antibody against it? Yeah, so the positive negative thing is related to something referred to as that when you think about positive versus negative, right? This is also equal to, they'll call it RH factor, but it's also equal to the D antigen. The D antigen. So this is a protein. Aren't antigens proteins?
Yes.
That you may or may not inherit. Well, guess what? My red blood cells have, well, I didn't draw that like I wanted to. But I wanted to draw it like a triangle because it's a different shape, right? So anyway, I can't draw a triangle because this is printing where I don't want it. But anyway, it's a very specific shape protein. And if you have that protein on your red blood cell membrane, you're said to be what? You're said to be positive. If you don't have that protein on your membrane, you're said to be what? Negative. You get what I mean? You get what I mean? So if you inherited the recipe for the D antigen, you're said to be positive. I'm A positive. Anybody else in here A positive? All right. So if you don't inherit the D antigen, you're just said to be negative. It's also referred to as RH negative, right? Or RH positive, depending on. Now here's the thing. Let's say this person is B negative, or this person O is O negative. Is this person going to naturally make antibodies against the D antigen?
No.
Why not?
Because it hasn't been introduced.
Because it hasn't been introduced. These are naturally occurring antibodies they will make. But they won't make an antibody against D unless they get introduced to it. Are you hearing me? So this means that people who are RH negative, should they ever be introduced to the D antigen?
No.
No. So people who have the RH negative factor, or they're RH negative, right?
Yeah.
They don't have the D antigen. Don't give them positive blood. Because if you do, they will make an antibody and then they will have it circulating, won't they? And we don't want that happening. We don't want to create an antibody that they might have to deal with later in their life if they were exposed to it, the antigen. Do you get what I'm saying? But a person who's positive, can I get negative blood?
Yes.
Sure. So I'm A positive, and I can get A positive packed cells. But can I get A negative?
Yeah.
Yes, of course I can. Because the negative doesn't have an antigen for it. Yeah, of course I can. Do you get that? But if I were A negative, would I want to get A positive? No, because that D antigen would look very foreign to my system, and I would end up building a what? An antibody against it. Are you hearing me? So let me say this about packed cells. Which of these donors do you think, which of these donors, their packed cells, theoretically, just their packed cells, theoretically would be a universal donor to the other groups? Why do you say that?
Because it doesn't have any antigens.
Because these packed cells, and especially O negative, because it means they don't have A antigen, don't have B antigen, don't have D antigen, and if you're just giving the packed cells, then it won't matter that these people have antibodies because you didn't present the antigen to them. What does the damage? The antibodies in the patient's serum or plasma. So you don't want to present the antigens to them because that's what does the damage. Do you hear what I'm saying? And it's as simple as that, really. It's as simple as that. Let me ask you about these people. Instead of them being patients right now, let's just think of them as donors. Okay. So we're thinking of them as donors. And you said somebody who's O negative, it would be nice to use their packed cells because their packed cells have no antigens that could elicit a bad response in any of the patients, theoretically. Which of these donors, think of them as donors, would you like for fresh frozen plasma? Fresh frozen plasma. So now you're thinking about their plasma. Which one would you like for fresh frozen plasma be the most attractive to you? Which AB? The AB positive, because guess what? Could an AB positive donor have antibodies against A? Could they have antibodies against B? Could they have antibodies against D? So their plasma is lacking any antibodies. And what is it that does the destroying? Antibodies. So a person who's AB positive, I have a daughter who's this, and they're calling her all the time. Can she come in and donate? Do they want her packed cells? No, they don't. They probably don't throw those things away. What do they want? They want her plasma. Why? Because it's zero antibodies. And what is it that does the destruction? So that's why you have to ask about your patients who are receiving packed cells. The first question you ask is, you've got their blood type, but you have to ask, this is a person who's blood type B, but what is in their plasma? What is in a person's blood type B plasma? Antibodies against A. So would you ever give them A packed cells? No, you do not. A person, you've got a patient, and by the way, most people are O. That's the predominant blood type. It's the recessive blood type. But this is the predominant blood type. Most people are O. Can you give them A?
No.
Why not?
Because they have antigens.
They have antibodies against A. Can you give them B? No. Well, how about AB? No, because they have both with the antigens and they have antibodies against both of them, right? If you have a person who is Rh factor negative, would you ever want to expose them to a foreign antigen? No, because what will they do? They'll develop an antibody against D. Now let me say this to you. They won't do it the first time. It won't hurt them the first time. But if they ever got that blood again that had a D antigen, would it hurt them then? Yes, it could kill them then. So you don't do it. You hear what I'm saying? If somebody's Rh factor negative, do not expose them to the D antigen, to positive blood. But if somebody is positive, they're never going to make an antibody against an antigen that they have. So if somebody's positive, you can give them negative blood because it just means that there's nothing there. There's nothing there. There's no A antigen. There's no B antigen. There's no D antigen. This person doesn't have a D antigen, do they? No. Are you good with this? Now you're not memorizing a chart, you're understanding. You're understanding, oh, it's my patient, I'm giving this to my patient, and what I have to ask myself is what is in my patient's plasma? And what's found in plasma? Potential what? Potential what? Antibodies. And you have to ask yourself, what antibodies? Are y'all good? What antibodies might be in their plasma? Because you're going to know their blood type. That's a whole band that they got for you, right?
So you're saying somebody with type A might not have the antibodies for B? You saying that's a possibility? Because when you say,
Did I say that? If I did, I
no,
was wrong.
you didn't. But you said they might possibly have it. That's why I was just wondering.
No, I'm saying depending on their blood type. But if you know their blood type, you know what antibodies they
So
have.
they've done.
Yeah, you do. Now, here's what I'm telling you about the D antibodies. So you've got a person who you get their blood type, and their blood type is negative. They're Rh negative. And they may be A negative, or B negative, or AB negative, or O negative. But they're negative. The reason that in a perfect world is when you're giving transfusions, the lab has already done a like they actually are using scopes to look at these transfusions. They're actually trying to cross-match them, looking at a microscopic level what the cells are doing with this person's blood. Because if you see somebody who's negative, you don't know in their life if they ever got exposed to the D antigen, right? So you really don't want to ever present that because they may have antibodies circulating to D. So you really don't ever want to expose somebody who's Rh factor negative to D blood, to positive blood. You don't. Are you good with that?
Mm-hmm. So what happens if somebody, like if I donated blood and I was negative, but I had the antibodies for D?
Okay, so when you donate blood, that we're going to do a little blood typing thing in here that's on a little card. It's kind of quick and dirty blood typing, but in a real lab. They're keeping the blood at 37 degrees. They're using little micro pipettes. They're keeping it warm in little incubators. And they're looking at it under a scope to see reactions. And they're doing what's called a front typing. So they're going to take your package, and you don't have to know this, but they're looking at the red cells, seeing what antigens are there, but guess what else they're doing? They're taking your plasma, and they're seeing what antibodies you have. So people who are Rh negative, before they would ever be given, and actually everybody, they're going to do what's called the front typing and the back typing. The back typing is what's being done on the plasma, looking for what? Antibodies. So babies that are just born, would it be any reason to do a back typing? No, because they haven't developed those naturally occurring antibodies yet. It takes a few months. But can you figure out a baby's blood type by doing the red cell?
Yes.
The front typing? Yes, you can. Does that make sense?
So, go ahead. Sorry. So I'm saying, like, if I was negative and I had the antibodies for D, meaning that I was exposed to it.
Yes, exactly.
Would my blood be tossed out if if somebody else was a negative person? And like, could I not give blood to another negative person because I have the antibodies for D?
They would use your pack cells. They would use your pack cells, but they would denote.
Yeah, for the plasma.
Yeah, for the positive, but they would denote your plasma.
So
and
they
may not even use your plasma.
That's what I was
Yes, yeah. But they would definitely like your pack cells. They would like them because negative blood can be a bit given to positive or negative. You know, so they would really like your pack cells. All right. So, did you have a question, Andrea?
I did.
Okay.
With pregnancy, I had to get. I'm ONEG.
So you had to get
I had to get the shot.
the Rodan.
What exactly does that do?
I'm going to show you.
Okay.
Good. Good. All right, so just this is a picture that's in this newer thing for us. So, you know, when you're thinking about blood being kind of smooth and whatever, what happens if you present an antibody to someone, if you present the antigen, someone who has the antibody, the blood will start clumping. And it will start clumping right away. It's going to clump on those little cards today if y'all see some of those. And if it starts to clump, you understand that as those clumps form and you're getting to smaller and smaller veins, what's it doing to those veins? Blocking them. And it's doing this in the filters of your kidneys. And it's shutting the kidneys down. But it's doing it systemically throughout as well. So this is just not a good thing to have happen, right? When it does happen. But I do want to talk to you about a woman who is Rh negative. So women who are Rh negative, and you know, this has been around for, I want to say, 50 plus, probably like 60 years. I think the first time they recognized that they could give somebody this that's Rh factor negative. I think it was in Australia that this first happened. And this guy ended up saving so many lives by this. But anyway, let me tell you what's happening when you are an Rh negative woman. If you're Rh negative, I don't want anybody to be all upset about it. Because like I said, for 60 years, we've known this. And it's protocol for part of prenatal planning. They draw your blood when you first come in. Guess what they're looking for? Unless you tell them that you are at risk for other things, they're really doing this. They're looking to see what Rh factor you are. And if you are negative, they're going to set you up for at 20 weeks to get a shot of Rogaine, and within 72 hours of delivery, you'll get another shot. That shot is kind of a thick, viscousy kind of shot. Did you think it was? I mean,
I just tried not to look because it hurt.
Okay. Yeah, your butt. Yeah. So, you know, I mean, it is kind of thick, but what it's doing, let me tell you, and it's wonderful, because I just can't tell how many babies' lives have been saved by this. But what it's going to do is, if they do it at 20 weeks, just as an overkill, over precaution, better to give somebody a painful shot than to have something else happen to the fetus. But what they'll do is, the really important one is after delivery, because you know delivery sometimes can be bloody. And what can happen when the umbilical cord gets cut, and you know you've had some tearing and whatnot, when that umbilical cord gets cut, is some of that blood the baby's blood, and then you have the mothers too. But if a baby is positive, Rh factor positive, and that umbilical cord gets cut, or any blood from that baby gets into any kind of little, tear or whatever the mother, it would take a little while, but that foreign D antigen would be recognized by her immune system. And what would she end up producing? The D antigen. And would she have it forevermore? So the question is, the answer to the question is, when they give you that Rogaine, it is actually a complementary structure to the D antigen. It's a molecule, it's immunoglobulin, and it is absolutely going to seek out that D antigen and mask it. So the mother's immune system won't recognize it as foreign. It'll just be, it's almost like it disappeared, it's cloaking it. You get what I'm saying? Because it has the complementary shape to that, and it works. For 60 years, we've had women who are Rh negative able to have more than one pregnancy, viable pregnancy. Back in the day, if you have anybody back in your history that said, that you knew, oh, my grandmother had one viable pregnancy, and then she had like 4 stillbirths or 5 miscarriages for stillbirths. Guess what was likely the problem? This incompatibility. Exactly. Yes. Because what happens is, if you don't get the Rogaine, and it's just a shot, but if you don't get it and you're negative, you could make antibodies against the D antigen. And if you get pregnant on the 2nd, 3rd, 4th pregnancies, and that fetus is positive, listen to me carefully, mothers and maternal blood never should mix. They never, ever should mix. But some things can cross from the maternal blood to the fetal blood, like nutrients, right? Oxygen and nutrients, and waste can come back to the mother, so the mother can get rid of the waste products from the baby's normal metabolism. But then one other thing can cross from the mother, and that's for protein antibodies. But in this case, when these antibodies against D cross, what are they going to attack on this second, third, fourth pregnancy? The baby's blood. And these babies are going to not make it. You get what I mean? Now, with modern medicine, there have been some women who had this situation that wanted subsequent pregnancies and decided to go for it. It's an extremely high-risk pregnancy. And what they will do for these fetuses is actually in utero routine complete blood transfusions. And it's a really high risk because even doing that still is usually going to cause neurological damage to the fetus. So this is referred to as hemolytic disease, one of the hemolytic diseases of the newborn. What did I say hemolytic meant? HDN. What'd you say? Hemolytic means what?
Splitting of the blood?
Yeah, the red cells are starting to lyse. They're going to start to break down and lyse. This is hemolytic disease of the newborn due to Rh incompatibility. And so that's why you get the shots. And they work. And they work, which is wonderful, right? So I tell people, it's not like I don't care about men getting positive blood if they're Rh negative. I mean, because it shouldn't happen. Not in our, not as long as, things are working. It shouldn't happen. But if men get it, the first time they get it, it's not going to hurt them in that first transfusion. But then could it hurt them later if they got it again? It could. So really nobody that's negative should ever be exposed to positive blood.
So I have two more questions.
Okay.
One, did that make my blood type change from O negative to O positive?
No, absolutely not.
Okay, because of the antigen shot. That's why.
What is
that?
No, because that's just the only thing. The only thing the shot is doing is seeking out potential red cells from the baby that might have entered your system,
Okay.
and it's covering them.
Okay.
For you to be positive, you would have to have the antigen, and so it's on your red blood cells. And the only way to have antigens on your red blood cells is to do what? Inherit them.
And then,
Does that make sense?
so that won't affect the baby's blood typing at all.
And
That doesn't.
mothers and fetal blood never mix. This fetus is an alien to your immune system.
I meant because of the antigens, not antigens, because of the antibody. Because I'm seeing, maybe I'm just confusing
Antibodies
myself.
can cross. Antibodies are little proteins, and they can cross the placenta.
Okay.
Or proteins that can cross.
Okay, I
But
got you.
you understand your blood type, like I do have one child. I was going to say, do I have any children that are my blood type? I do have one child who's my blood type, but I have two children who are completely different blood types than me. Because your infants your fetuses that you carry are aliens. If blood were to ever really mix, it's usually going to destroy the fetus because your immune system is going to think that's an alien and get rid of it. Maternal and fetal blood never mix. I had an RN one time who was the administrative RN, administrator of the hospital, came in and said, I just don't understand, how can the baby have a different blood type than the mother? I was like, I don't have enough time to talk to you. I don't. But anyway, do you get what I mean?
Yeah, I was confusing antibody and antigen.
Yeah, so antigens are found where?
On the red blood cells.
Red blood cell membranes. Where do you get the information for your antigens? From your parents, from their DNA. What's found in the plasma?
The antibodies.
But what's the only naturally occurring antibodies you'd ever have? Antibodies against A, potentially, depending on your blood type, and antibodies against B, depending on your blood type, right? So if you're blood type O, you have antibodies against both of those, don't you? Right? But will you have naturally occurring antibodies against C?
No.
Only if what happened? Only if you got exposed to the D antigen. That your immune system, rightly so, would say, this is something foreign. I'm going to make an antibody against it. And then you keep them. You keep those antibodies. All right, so let me tell you that this is actually, I called it one of the hemolytic diseases of the newborns, and it's one of the more severe ones. But there are also other minor blood typing things that can happen. But I do want you to know this is the severe one. It's called hemolytic disease of the newborn. It is also known as erythroblastosis fetalis. Erythroblastosis fetalis. And I don't know, that's somewhere in your notes here, but it's obviously in your book too. Does anybody know where it is from? So why is RhoGAM given again? Why is RhoGAM given?
Because it masks the.
Because it is actually a immune globulin that has the complementary structure. I want y'all to really think about that. If this were the D antigen, they could be on little red blood cells. This immunoglobulin that's given has the complementary structure to this. So it's not going to react with anything else. It's not going to, but if it finds these little red blood cells, what's it going to do? It's going to hook up with them and mask them, so that when the mother's immune cells are going by, they don't recognize it as being anything foreign. They don't even see it. Do you get what I'm saying? And this has been effective and worked effectively for decades. I think that's really cool, isn't it? That women can now, because before this modern, I know y'all are thinking 60 years, that's like forever. No, it's not. Like, I know people who had Rh incompatibilities and had only one viable child, the first one.
So they could get pregnant and not have the
They
positive.
can. If they get pregnant with someone who's negative, if the fetus is negative, doesn't have the D antigen, it wouldn't matter that these antibodies are crossing. There would be nothing to react with it. But what's the most common blood type? Positive. And the father, well, they could go pick somebody else.
So
They could say, wait, I need a new baby daddy, and I need you to tell me if you're Rh negative or positive. Because if you're negative, then we can have a second, third child. Yeah.
So
Okay, I was trying to be funny this time.
if one of them is positive, is the baby automatically going to be positive?
No, but it's 50-50.
Oh, it's
50-50.
What if you have to get the shot every time you get shot? Yes. But
let me tell you this, because you're bringing up something that's really important. So let me say this. There have been women who come in and they're Rh negative, like Andrea. And she finds out that her husband is Rh. And so, Andrea, not that you do this, because you don't mind the shot. Because it's really, once you ever get pregnant, it's never about you again anyway, in this entire life. Never about you again. Get over yourself, because it's never about you again. But there have been women, and this is going to happen. If y'all work in OBGYN, you're going to see it happen. There have been women who come in and say, well, my husband is Rh negative too, so we can't have a fetus that's positive. And is that theoretically true? Well, let me tell you, it's a dominant inheritance. So is it true if they're both recessive, could they have a positive child?
Yes.
No, guys. If they're recessive, they don't have anything to give.
The RH
So
factor
the Rh factor is dominant. But if two people are recessive, could they have a fetus that's positive? No. But let me say this: positive is more common, right? In others. So you'll have a woman come in and she'll say, "But my husband tested and he's negative, and so I don't need that shot, and I don't want that shot because he's the father of the baby." And you know what? That's wonderful, but do you care who the father of the baby is? Andrea, I don't care who the father of your baby is. I care about your baby surviving this. So you're getting a shot. Because I know you say that's the father, and that's really sweet, but you're getting a shot. You get what I mean? Because you just can't, you have to, it's the baby's life, right? It's the fetus's life. And so you're getting a shot. So, right?
So is that not even an option? Like they're getting it regardless?
They're getting it.
That's what I would.
If this is a medical thing, now people can refuse medical care.
Right.
They can walk out and try to go somewhere else and get a midwife somewhere and do something.
Right.
But no, protocol says they're getting it. It's the same reason about the drops in the eyes that prevent blindness. Do you know how common gonococcal blindness and chlamydia causing blindness in the world today? Number one causes are chlamydia. So you have these people come in and say, no, but we're monogamous. We've never been with anybody but each other. And so we don't have any of those diseases. And you think, I don't care, and put a drop in each other. Actually, you don't say that out loud. You're thinking, okay. And then behind them, you put a drop in each other. You know? So you just do. So, anyways, protocol. Protocol. There will be people who walk out, though. They will. It will hurt their feelings. And you know, they're the people who they think it's all about them. I mean, that should not be. Did any of y'all do that? Nobody did that in here. I mean, just why would you do a and it really can be true. I actually had a student who said that they had worked for a physician who took the word and said, oh, well, if the dad was negative, okay then. Guess what time it is for that patient? Time to find another physician. Because that's just not good practice, is it? What was your question, Nancy?
I had a patient that studied at times. She had a newborn child, and they told her no, that she had to stay for
The 24 hours that they can do the PKU and all the thyroid testing. It's just a drop of blood from here.
and she refused to stay. She left out. As soon as she left out, she dropped, and she's paralyzed now because she did not want to listen. So the child is with the dad. She can't take care of it.
I didn't hear what she had, though. What happened to her? I mean, why was she?
She was told to stay, and she didn't stay.
And then some complications happened because, you know, again, protocols are usually set up not to be judgmental or not to be anything. It's just because of what we see can happen after certain times. So, and if you've seen it enough, then certain protocols are set up. And it's mostly to help the patients, but sometimes it's also to protect the facility. So, so protocols are set up for different reasons, and some people might think that we have way too many regulations, and I would say that's a good argument. There are a lot of way too many regulations for things, but the things that are set up to prevent preventable things don't seem like there's good arguments to not. Do you know what I mean? So, you know, there are reasons that protocols. I get kind of crazy about emergency medical care and all the protocols that are set up. It seems like a lot of those protocols are set up more to help to protect the professionals and the facility. Yeah, and y'all know that. So it's like if you have a protocol, if you in the ER, if you have a baby under a certain age that has fever of unknown origin, and by the way, guess what fevers are in most babies? Of unknown origin, right? Because you never really figure out where that fever came from. Because the ears they look pretty good. There wasn't a urinary tract, you know. But fevers of unknown origin in little babies, and they come into the emergency rooms because sometimes patients don't have primary care providers and nothing's open, so they use the emergency rooms like clinics. But if they come in, that emergency room has protocols set up to protect them against litigation from those. And that baby's going to have in and out catheters, which then puts them at risk for developing urinary tract infections and often lumbar punctures, which are, you know, spinal taps. All because of what are usually 90+% just a fever that would resolve. Do you know what I mean? But because of protocols, they'll have to do it. And if they don't want it, they have to leave against medical advice. Right? So I don't know. But it really is. This has been set up to protect. So it really won't matter what your husband is. It you know, might not be the husband's baby. Just saying that has happened, right? That has happened. Yes.
Is the program considered a blood product? You know, like to certain religions refuse to get blood products.
You know what? I have never heard. I haven't been around when that is. I'm sure that has happened. I'm pretty sure that's probably happened. So, you know, there are a lot of things you'll encounter. Let's take a quick break and come back, and then by about, we're gonna come back and do a little bit, guys. Can we take just 5-10 minutes? Sorry, oh, the erythroblastoma fetalis. Okay, thank you. Actually say it was today, but I thought they wouldn't have sent it like this because they didn't say it was a different date unless it was at noon. So anyway, it's worthwhile to see. Okay. All right, guys. So just a little bit more, and then I'm going to set up for lab, and we'll take you on to set up, and we'll probably be done with this part after less than 1 time. All right. So guys, let's go ahead and think about white blood cells. Everybody good? So we're thinking about white blood cells, and what you should know is a basic how many white blood cells do you usually see. And usually you think about normal numbers as being about 5 to 10,000 per microliter of blood, so 5 to 10,000. But you know that not all white blood cells are created equal. So, but that's just a total white count. And I think I've given you all some the idea that that's where you'd like to see them falling. If you don't have enough, you would be at risk for opportunistic diseases. So if the white count's too low, leukopenia, then that can be a problem. Or if the white count's too high, it could indicate potential infections, right? And actually, if it's seriously high, then it can indicate even worse things like leukemias. So anyway, let's take a look at the individual ones. I think I had given you all some rough averages, haven't I? So you all have these, and you have, you know, basically what you're fighting against. So neutrophils in adults fight against, eosinophils against, allergies and parasites. Basophils, less than 1%, but they have histamines too, and they have heparin, so they play a role in making sure you don't have unwanted blood clotting. That works as an anticoagulant. And then lymphocytes, we said about 25% or so. And you're thinking about like viruses or cancer. Do we have cancer cells that are happening every day? We do, but that's okay because we have strong what? Immune systems. And we have these cells that sort of take them out and destroy them before they can even cause trouble. And I told you monocytes 2 to 8% or so. These act as our large eaters that end up cleaning up debris. They're going to be kind of the ones that first rise. And I know your textbook says that they're the first to rise in like viral infections. They're the first to rise in any infection. So when you get a blood film of somebody or a blood report back, and you're seeing maybe blood counts just borderline high, but you're seeing those monocytes go up, are you thinking there's an infectious process happening and maybe just starting to happen? So when you look, I'm going to stain y'all's blood films after you do them today. I'll stain them so they'll be ready for you next week to look at. I use a white stain. It's the most common stain used in hematology labs. And so the red cells are going to kind of look like this. We said they look donut-y shaped. But anything that's got a nucleus, whether it is a segmented nucleus or whether it's binucleated, looking like two, or whether they have big granules, the white cells don't all look alike. And so you're going to see they're very distinctive in how they look. Now, these are using some other things. So like a neutrophil would look like this. This is going to be an eosinophil with these big pinky orangey granules with the right stain. Basophils, which you might not see at all, but that's okay too. Lymphocytes. The lymphocyte is not much bigger, a mature one. It's not much bigger than a red blood cell. It has very little cytoplasm and almost all what? It's almost all nucleus looking, isn't it? And the nucleus is really round with very little cytoplasm. Even if it's a young lymphocyte, it's still not going to be that much cytoplasm. Monocytes, and these you don't see, like this is the thing. The monocytes have a really huge folded up nucleus that's said to have like a ground beefy appearance, but it's big and it has more cytoplasm than lymphocyte. You'll get used to seeing them. So when you actually start doing your blood differential, you're going to scan around. And as you scan around, you'll say, oh, yeah, okay, that's what a seg looks like. And this is what a monocyte looks like. And this is what a lymphocyte. And then I'm going to get you to do a blood differential, which means you're going to and you can do little hash marks. You're going to count 100 white cells. Try not to repeat any white cells you've already counted. So you're going to move a very specific, your microscope slide, a very specific way so that you're not repeating, just counting the same white cells. And when you get to 100, you stop. Cells, you stop, and you see how many you counted. That's called an absolute count, an absolute number. So if you had 62 out of the 100 that were neutrophils, that's 62%, right? A hematologist that does these can do them in less than a minute. They can do a patient's blood differential in less than a minute. Y'all have to be in a hurry, so nobody's going to time you. But you're going to just kind of get a feel and an idea, and you'll think, yeah, okay. The last group that did these, that I have another section of AMP2 going on right now, I had a couple of students who had lymphocytosis, so they had really high lymph counts. But what do we think was probably going on? The virus. Exactly right. So sometimes I see students who have a really high eosinophil count, so allergies, whatever. So you're going to be able to see this. Great. And y'all are going to match their functions to what they do? Yeah. So what we understand is all stem cells that become our peripheral circulating cells come from the red bone marrow, don't they? So they come from the red bone marrow. That's where the stem cells are found. Depending on what these are referred to as like cytokines, these groups of molecules that are going to target these stem cells. And anyway, they're also sometimes referred to as colony stimulating factors. It's going to depend on what that stem cell will become. Okay, so if it's viruses or whatnot, they release the type of colony stimulating factors that are going to form lymphocytes. If it's bacteria, these are going to go up. You get what I'm saying? So depending on what you need is what you're going to get. So should we as diagnosticians listen to that and pay attention to that? Yeah, because it can get us going on in the right direction. So these terms you've already had to, just wanted you to know. Leukemia, when somebody's diagnosed with leukemia, it can be of any of these cell lines. So depending on what cell line is involved, what you're going to see when somebody has leukemia, guys, are going to be people, and sometimes the first thing you see is actually the platelet counts are off. So you're going to end up seeing the platelet counts dropping, and could really drop really low. And so sometimes what you see and it's really leukemia, but it's affecting the platelet counts, and you'll see bruising. So a lot of bruising. So patients will come in and they've got and when I say a lot, I mean significant, like bruising. Like they don't even know why they're having these horrific bruises on them because they didn't do anything. It's not like they had any reason to have. And I'm not talking about just little, like you can get with aspirin or something. I'm talking about serious bruising. And then they have blood work done, and what they end up seeing in the peripheral blood film are blasts. And when these blasts are being pushed out into the peripheral blood film, it's leukemia. So y'all have probably heard of acute lymphocytic leukemia, haven't you? Or chronic lymphocytic leukemia, CLL or ALL, have you heard of those? Or maybe you've heard of myelogenic leukemia, AML, acute myelogenic leukemia. It's a different cell line. So depending on what type of leukemia, do you think it affects the prognosis? Yes. Yeah. And in adults, acute leukemias usually have a shorter lifespan expectancy than the chronic ones. That is the opposite in pediatric leukemias. In pediatric leukemias, the best prognosis is an acute lymphocytic leukemia. And they have now over 90% cure rates. Isn't that wonderful? We always hear the bad news about cancers, but there's some cancers that are very effectively treated, and especially, certain ones. So, so again, is pediatric medicine just kind of a completely different beast than adults? It really can be. Anyway, do you have any questions about that? So what we want these mature white cells being in the peripheral blood, doing what they need to be doing and working the way they need to be working. I have some films from UVA, some blood films that I got in there that show you what leukemia looks like. So instead of when somebody has leukemia and you're looking at their blood film, so instead of seeing a blood film that would look, well, I'm trying to find a good one. Okay, instead of seeing a blood film that would kind of look like this, where every field of view, you're mostly seeing, hundreds of red cells, and you'll see, one white cell to maybe 6 or 7 in one field of view if you're kind of lucky. You need to be looking at an area where the red cells are not stacked on top of each other, where they're kind of spread out. This is called the feathered edge. That's where you have to do a blood differential. And you'll see per field of view, maybe up to 5 or 6. Person who has leukemia, it's packed with these cells, these white cells that end up just packing it in their blast. Yes.
Is there a virus that can mimic leukemia? I went like 7 years ago. I went to urgent care.
Yeah.
And I was so
That's so nice.
I was so tired. I was sleeping like 20 hours a day, and I had a lump right here. And I went in, and the doctor told me, he's like, you either have leukemia or you have AIDS. He's like, it's one of the two. So he freaked out.
Did he have a C, an option C?
I don't know.
Okay,
That was my option. She's like, honestly, with
Had they already done a blower? Had they already done a blower?
he did. I think they took some blood. I don't even remember because it was so long ago. And then he's like, yeah, you need to go like to somebody else. So then I rushed up to New York, and then I went to an internalist who took me to a specialist, and because I guess like the count was like so significant, but they were like, I think it's just gonna go away within 2 days.
Yeah, and it did. So there's some viruses.
I never found out what it was.
One of
I don't have leukemia. I don't have AIDS.
okay.
And I was just starting dating my fiance then,
was
so like
option C was working.
I was just dating Josh. Like we just started dating. Like
That can ruin a relationship.
I was like, I was like, no, I don't think I have this. But imagine, yeah, I either have leukemia or have AIDS.
People should watch what they say.
Yeah, and then they try to charge me for everything, and my mom's like, tell my daughter that she's you're not charging us for anything. The doctor shouldn't have said anything. It was the only.
So there are viruses, because viruses are going to increase. You're going to get an increased white count rate. There's some viruses that can cause your lymphocytes and monocytes to look atypical, but they're called atypical lymphs. And if somebody isn't knowing what an atypical lymph looks like versus an monocyte looks like versus blast, they can be alarmed when they look at a blood film. But you guys have heard of mononucleosis. It's a virus caused from a virus called the Epstein-Barr virus. And one of the easy diagnoses for that is your blood differential, because what you're going to see are these atypical looking monocytes that can, if somebody's not knowing what they're looking at, if it's not a true hematologist, they can think that they're blast in the peripheral blood. And the counts can be high.
I think he was just looking at the counts.
Yeah, the counts can be high, but that's why you do the blood differential, because then you're identifying what they are. And atypical lymphs and atypical monos are really common. They're common with a lot of viral illnesses. And our swollen lymph nodes is fairly common. Lymph nodes can get huge.
It was so weird because it was only on one side though.
Yeah, well, that's not weird. That's not actually weird. It's you don't necessarily have bilateral lymphadenitis. So it's usually just one sometimes that will really get huge. But you have to rule those bad things out. So you do have to go through and get some testing done and rule bad things out. Sorry.
Yes.
But the good news is you did rule them out. All right, so and we're all happy about that. But yeah, some things can actually get really scary looking. It's so funny that when students do their blood differential and they've heard this part, they're like, I see them. They're looking for something awful in their blood. What are you doing? Well, and they're over in like the really thick area of the blood film. I'm like, I told you to do this in the, I told you to come out here to the feathered edge to do this. And I was looking for a basic. I was looking for so-and-so. Okay. You don't have any of those. It's all right. So, all right. I think that this is good for now. I'm going to get this ready. Y'all can go get some food if you want to. It shouldn't take us more than, after we get set up, let me tell you, I'm going to want a couple of people to let me use them to show you how to do this. You, Rayana? All right. And so So I'm gonna do that, and then if you wanna do your own, you can. But if you don't think you can do, these are little gun finger sticks, and finger sticks hurt worse than phlebotomy, don't they?
Yeah.
Finger sticks do hurt a little bit, but only for a second. But look, if you don't think you can really get a good finger stick and good blood stains, then you're just gonna make a big mess, and you're not gonna have your blood film, you're not gonna be able to do your blood type. So if you don't think you can do it yourself, you might want to wait for me, and I'll do it. I can change gloves in between everybody, of course. Of course, I would do that. I wear gloves to protect myself, just like you do with patients. And I would be inverting the gloves and getting new gloves for each new person. So if you want me to do it, I'm happy to do it, but I want you to watch at least 3 before you would attempt to do your own. Okay? Yes?
Are we having a lecture study guide or quiz?
Okay, so thank you. I'm going to put this lecture recording up, and you are not going to have a study. Don't worry about doing your study guides for this, because what should you do between now and Tuesday? Because there's a test, and you've got to try to do as well as you can on these tests. Have I directed your study for these tests? Your study is what we said out loud. Your study are the deeper insights and the disorders. The deeper insights are the disorders. My couple of new people, we know, Madeline, you know deeper insights. Charlotte, you know what I mean when I say deeper insights and disorders in the book? Will you show her,
Yeah.
Janae, or Nicole, or whoever's around her? Yes, Alexis.
You answered that. I was just gonna see, is the chapter test strictly on the hormones, or was it gonna include the deeper insights and whatnot?
No, the test always includes deeper insights, disorders, and yeah, any lecture material on the endocrine system. Fair? All righty. And y'all won't have you will not have a lecture quiz. Do you have the lab to do? The 10 organs, major organs, you do. And the test, but you will not have a lecture quiz on this.